Ευχαριστώ πάρα πολύ. Ευχαριστώ κυρία Τσολιά, κυρία Συριοπούλου. Χρόνια πολλά σε όλους. Είναι ιδιαίτερη τιμή μου σήμερα να βρίσκομαι εδώ στο Μητέρα, επειδή έχουμε φτιάξει και μια πολύ καλή συνεργασία γύρω από την αντιμετώπιση των λοιμώξεων στο παιδοογκολογικό της κυρία Κοσμίδου και τη ευχαριστώ πάρα πολύ για αυτή τη συνεργασία. Για αυτούς που έχετε ξανάρθει σε ομιλία, τις ομιλίες μου τις λέω στα αγγλικά, επειδή η γλώσσα του επαγγέλματος είναι στα αγγλικά, τη συζήτηση μπορεί να την κάνουμε στα ελληνικά αν θέλετε. Okay. By way of overview this morning, I'm going to try to touch on 4 different topics. Antibacterial prophylaxis in pediatric oncology patients, antifungal prophylaxis, empiric therapy for fever and neutropenia, and infection prevention and control. This is really an update. There are some recent data in each of these areas that I think are worth discussing today. And I also am going to raise some controversies, some very controversial topics around antibiotics in the febrile neutropenic child. So what is the impact of bacteremia? You heard already from my colleague. Bacteremia is one of the most serious complications in pediatric oncology patients. These are different protocols, both from Europe and the United States, that highlight the significance of microbiologically documented bacterial infections. In AML, BFM 93 and 98, there were 72 treatment deaths. 40% were due to microbiologically documented bacterial infections. In the AML protocol in the United States, 50 to 60% of patients sustained a documented bacterial infection, with the infection-related death rate being about 11%. And on, you can see there the rest of the data. In an ALL protocol, 55% of infections were bacterial, proven bacterial infections, and 68% of those deaths. So the take-home message from this slide is that bacterial infections are a significant cause of morbidity and mortality in pediatric oncology patients. But beyond the mortality, what else happens to children who get a bacterial infection? They get delays in chemotherapy, right? The goal is to treat the child's cancer, but delays in chemotherapy make that more difficult. They lead to prolonged hospital stays, costs, psychosocial implications to the families and to the child. And then when we treat infections, we can get secondary complications of treatment. Clostridium difficile. It's very interesting. If you look at the epidemiology of C. diff infection in pediatrics, 25% of those infections are in pediatric oncology patients. Organ toxicity from antimicrobial agents. We give nephrotoxic antibiotics, which in combination with some of the other drugs children with cancer receive have an impact on the kidney. Organ complications from the pathogen immune response. We know the immune response in children with cancer is much more complicated and debilitated. And then, of course, there's the evolution of resistance. So is it possible to eliminate bacteremia in children with cancer? Not a chance? How many people say not a chance? Professor Katamis? Maybe, but not worth it? Maybe, and it's worth trying? Definitely. I fall somewhere between C and D. Why are children with cancer at such high risk for bacterial and fungal infections? I mean, if we look at the impact of cancer therapy and the therapies associated with treating children with cancer on the immune system, they are pretty incredible. We have barriers, breakdown in barriers, skin integrity. We put central lines in these children. Surgery, radiation, cytotoxic agents, and steroids all impair complement system, natural killer cells, cell-mediated immunity, antibodies, phagocytic cells. Every arm of the immune system is affected by the things we do to children with cancer. Really, I show this slide to make a point that we need to understand the epidemiology of bacterial infections in your specific unit. It varies. Here's just examples across several centers in Europe and across several malignancies. The proportion of gram-positives and gram-negatives may vary by cancer type and by center. So when you're thinking about treatment or what your treatment guidelines or protocols will be or what your prophylactic strategy will be, you need to understand the epidemiology in your specific hospital or in your specific unit. So what are the different approaches to bacterial infections? There's prophylaxis, which means to prevent it before the child has any signs or symptoms of infection. There's empiric therapy, meaning when there is concern for infection, we start antibiotic therapy, and definitive. I'm not going to spend a lot of time talking about definitive treatment of bacterial infections, but I will talk about prophylaxis and empiric therapy. Antibiotic prophylaxis. These are a number of major studies published now 10, 15 years ago in the New England Journal of Medicine. And if you look at these studies, they were exclusively adult studies, and they looked at quinolone drugs, levofloxacin. The 2005 study found a reduction in bacteremia from 34 to 18% with the use of levofloxacin. A study by Cullen, 1,565 adults. Levofloxacin group had 6.2% bacteremia rate versus 7.9 in placebo, so very close, no major difference. And then there was a Cochrane evidence-based review, which showed that if you take all the trials that compared quinolone versus placebo, the quinolone bacteremia rate was 10% versus close to 17% in the placebo. So the adult studies have suggested that levofloxacin prophylaxis or quinolone prophylaxis is effective in preventing bacteremia. A meta-analysis of 17 placebo-controlled trials found a relative risk reduction of about 50%, between 48 and 62 in all-cause mortality in patients who got fluoroquinolones. The majority of patients in this group were hematologic malignancies, or those who had bone marrow transplantation and who had neutropenia that lasted for more than 7 days. So the patient who has significant duration and depth of neutropenia. But we're here to talk about pediatrics today. We do not know the true impact of prophylaxis in children. In 1983, Phil Pizzo, who's the grandfather, I would suggest, of fever neutropenia in pediatrics, conducted a randomized clinical trial. And to see how old these data are, they used trimethoprim sulfa for prophylaxis and erythromycin. And they found no difference in rate of bacteremia. That's probably because those drugs are the not optimal drugs to treat or to prevent bacteremia. Contemporary pediatric data is limited to small studies with limited power or retrospective comparative studies. But now, this past year, and I want to spend a little time talking about this study, we have this. This was published in JAMA at the end of 2018, effect of levofloxacin prophylaxis on bacteremia in children with acute leukemia or undergoing hematopoietic stem cell transplantation, a randomized clinical trial. This, I think, is the definitive study in pediatrics now. It was done through the Children's Oncology Group. They enrolled 624 patients, 200 with acute leukemia and 424 who underwent bone marrow transplantation. The patients were randomized to levofloxacin prophylaxis during every cycle of neutropenia versus placebo. And what did they find? In the patients with leukemia, the bacteremia rate in the levofloxacin group was 21% and 43% in the no prophylaxis group, for a reduction of about 50% in bacteremia in the leukemic patients who were receiving levofloxacin prophylaxis. In the bone marrow transplant population, the bacteremia was 11% in the levofloxacin group versus 17% in the no prophylaxis group, a reduction of about 38%. And the bacteremia rates per thousand were significantly decreased in the levofloxacin group. They looked at secondary outcomes, episodes of fever neutropenia, severe infection, invasive fungal disease, and C. diff, and they found no difference in severe infection, fungal disease, or C. diff associated diarrhea. but there was significant difference in the levofloxacin group. They had less episodes of fever neutropenia. And then finally, the question that we all ask about the use of quinolones, levofloxacin, because we know in adults they impact cartilage and joints and the musculoskeletal system. They looked at this outcome at 2 months and 12 months and found no difference in musculoskeletal adverse effects in children who were receiving levofloxacin prophylaxis, suggesting that it's safe. Finally, one of the things that we all as infectious disease doctors worry about when we give levofloxacin prophylaxis or any antibacterial prophylaxis is what is the impact of resistance. If we give children levofloxacin for weeks and weeks and weeks and months, what will happen? What was very interesting, there was no impact on resistance to levofloxacin or to any other of the antibiotics that we commonly give to children with cancer. So, one more. Let me show you one more here. And I think this is important too. The children who got levofloxacin prophylaxis had less exposure to gram-positive antibiotics, less exposure to aminoglycosides, less exposure to third or fourth generation cephalosporins, and less empirical therapy for fever neutropenia. So I would suggest that this study is a win-win across the board. It prevents bacteremia, it is safe, it doesn't predispose to resistance, and it actually reduces the total amount of antibiotics you give. I do not think we're going to get another 500 or 600 patient pediatric study to look at this question. So we're going to have to decide, are we going to make this standard of care? All right. Talking a little bit about empiric therapy now. Why do we do empiric therapy for fever neutropenia? Again, going back to Phil Pizzo, 1979, the American Journal of Medicine. He randomized 32 patients. We've based a whole world of work around 32 patients. He randomized them to either stopping empiric antibiotics on day 7 of neutropenia or continuing until count recovery. What happened? 16 patients here, 17 here, and what happened in the patients randomized to discontinue antibiotics, these Fs are people who had recurrence of fever and there were 2 deaths. So there were 2 deaths in this group, no deaths in this group, and we set practice for the next 40 years. What do the guidelines say? My colleague showed these guidelines. This is the 2017, and I feel fortunate that I was allowed to be part of this guideline committee. What do they say? What empirical antibiotics are appropriate for children with high-risk fever neutropenia? In high-risk fever neutropenia, use monotherapy with an anti-pseudomonal beta-lactam, which is a 4th-generation cephalosporin or a carbapenem in pediatric high risk. Strong recommendation, high quality evidence behind this recommendation. Reserve the addition of a second gram-negative agent or a glycopeptide, vancomycin, teicoplanin, for patients who are clinically unstable or when a resistant infection is suspected for centers with high rates. Dr. Baca asked this question earlier. The guidelines do not give a number, but the literature usually suggests that once your resistance rate of a specific organism to a specific antibiotic exceeds 10 to 20% in your center, you should think about either a second agent or changing the monotherapy agent. When and how should the initial empiric antibiotic therapy be modified during fever neutropenia? In all patients, discontinue antibiotics in those who have negative blood cultures at 48 hours, who have been afebrile for at least 24 hours, and who have evidence of marrow recovery. This is obvious. If their neutrophils are back, they're not febrile, and their cultures are negative, we can stop antibiotics. How about in patients with low risk, consider discontinuation of antibiotics at 72 hours in patients who have negative cultures, who have been afebrile, irrespective of marrow recovery. So how many of us are ready to do that? necrospiritis. So when to discontinue antibiotics? If we go back to Dr. Pizzo again, he actually said in that study and in subsequent quotes, supportive management of granulocytopenia requires careful balancing of the risks and benefits of antibiotic treatment. And the risk of developing a resistant microbial flora and or superinfection should be a deterrent to indiscriminate antibiotic administration. What's changed about fever neutropenia, and why should we think about this potentially in a different way? An increasing proportion of febrile neutropenic episodes have early fever resolution now. In the old studies, in the Pizzo study, early resolution occurred in 23%. In contemporary cohorts, resolution occurs in about a third. Plus, we now have viral diagnostics. So we can identify viruses often as a cause of the febrile episode. What are the risks? Well, we know that resistance is increasing worldwide. A point prevalence survey, 73 institutions found that consumption of antibiotics is highest on the oncology ward. These exposures translate to an increased risk of ESBL and carbapenem-resistant bacteria that are more difficult to treat. And then the increasing resistance rates will reduce the effectiveness of monotherapy. A lot of people are talking about the microbiome and the impact of the microbiome in immune development. Early data links the duration of antibiotic exposure to the temperamental stability of the oral or stool microbiome in adults during AML therapy. Temporal variability exists of the microbiome, and it's associated with infection during and after induction. The take-home point is more antibiotics may actually be increasing your risk of infection by altering the microbiome. There are data in graft versus host disease now that altering the microbiome may increase the risk of graft versus host disease in bone marrow transplant patients. Of course, we have to remember antibiotics have their own toxicities, allergic reactions, renal and hepato, especially again in light of these patients receiving multiple other types of drugs. So these risks need to be considered. So let's look at the data. If we were to think, is it safe to stop antibiotics in some children with fever neutropenia? This was the How Long study published in Lancet Hematology in 2017. Randomized clinical trial of empiric antibiotics in high-risk febrile neutropenics in adults. They randomized 157 patients to stopping antibiotics at 72 hours of afebrile or continue until count recovery. Short course arm had significantly reduced empiric antibiotic days, similar rates of recurrent fever, and less adverse effects. There were 4 deaths in the standard therapy arm, none from infection. 4 deaths, 3 in the standard therapy arm, sorry. In pediatrics, randomized clinical trial with fever neutropenia without a source, but reassuring clinical and lab status at day 3. Again, very similar. They found that stopping antibiotics was safe. Same study, same type of study here. Now, this is an older study published in about 17 years ago. Randomized clinical trial of children with resolution of fever, but still with neutropenia. They randomized these patients to oral antibiotics versus placebo, and they found no significant difference. So, for antibacterial prophylaxis, I think the study I showed you may change practice. And then I think we really need to start thinking about how do we want to change the old paradigm now of continuing antibiotics until marrow recovery. Switching gears to antifungal prophylaxis. In which of these patient populations would you routinely use antifungal prophylaxis? By show of hands, please. Bone marrow transplant. ALL. High risk. AML. Solid tumors. 1 and 3. Transplant and AML. All of the above. So, is there a role for antifungal prophylaxis in pediatric oncology? Absolutely in allogeneic transplant patients in AML. Probably in autologous relapsed ALL, and potentially in populations with severe aplastic anemia and hypoplastic MDS syndrome. doubtful in low-risk, non-relapsed ALL and solid tumors. And I think that's the sense I got from the audience. Does prophylaxis work? Yes. These are multiple studies. There's 64 trials at the time this was published, this meta-analysis, only 5 of which included children. And what you find is the reduction here is somewhere in the 50% if you average with the use of antifungal prophylaxis. This is a study published several years ago out of our group, and we looked at induction therapy for AML and the role of antifungal prophylaxis. Patients who did not receive antifungal prophylaxis had a death rate of 5.32. Those who got prophylaxis had a death rate of 2.42. This was statistically significant. One of the questions that comes up is which agent do you use for prophylaxis? And whether mold-active agents, an antifungal that covers aspergillus and molds, is necessary. And when we looked at this, we found no difference, but the numbers were very small. So I would not conclude anything from these data. So I asked the question, which antifungal agent would you use for prophylaxis? How many people are going to use fluconazole in the high-risk patients? Voriconazole. Amphotericin B deoxycholic, liposomal amphotericin B, echinocandin, caspofungin, mycofungin, okay. Or all together, give them all together, all 5. So fluconazole has been the gold standard for prophylaxis for greater than 15 years in bone marrow transplant patients. Classic studies, New England Journal, etc., all of them found significant decreases in invasive fungal disease. What about voriconazole? So this is a study that tried to address the question, if you give a mold-active agent, voriconazole versus fluconazole, what would happen? And all of us expected voriconazole to be better. It was not. There was no difference between fluconazole and voriconazole for prophylaxis in bone marrow allogeneic bone marrow transplant patients. Why? Because most of the fungal infections are candida. And fluconazole and voriconazole probably work equally the same. The number of mold infections is small that you will never be able to detect a difference, or at least in this study they were not able to detect a difference between the two. I'm going to skip this. The bone marrow transplant guidelines, fluconazole is the drug of choice for prophylaxis. Echinocandin is an alternative agent. If anti-mold activity is warranted, vori or posaconazole are options. They give you a lot of flexibility. In patients with graft versus host disease, the recommended agent is posaconazole for prophylaxis. And if the child has had invasive aspergillus, they should continue to receive secondary prophylaxis for recurrence of aspergillus. And voriconazole has been shown to be beneficial. These data have not been presented yet, but the manuscript is in press. So I'm presenting data that's unpublished, but I think is important for us to discuss. So I would encourage you not to discuss these yet, but the paper is in press. This is a Children's Oncology Group study, randomized, open-label trial of caspofungin compared to fluconazole to reduce invasive fungal disease in children with AML. This was a study that we ran out of the Children's Oncology Group. Multi-center, randomized, open-label trial. Patients 3 months to 30 years treated with AML. They were randomly assigned during the first cycle of chemotherapy to prophylaxis with caspofungin or fluconazole. Prophylaxis was given during each chemotherapy cycle. They looked at the primary outcome of proven or probable invasive fungal disease. Secondary outcomes were invasive aspergillosis, empiric antifungal therapy, and overall survival. All the fungal infections and outcomes were determined by blinded central review. This is the largest antifungal prophylaxis in pediatric oncology patients. Again, I don't think we're going to have another one this size. 508 children were enrolled. 253 got caspofungin. 255 got fluconazole. 23 proven events. 6 in the caspo arm, 17 in the fluconazole arm. 14 of these were mold infections, 7 yeast, and 2 were fungal infections that were not further categorized. So the incidence in the Caspo group was 3.1%, in the fluconazole 7.2%, statistically significant difference in the rate of invasive fungal infections between caspofungin and fluconazole. Aspergillosis, 0.5% in the Caspo group, 2.7% in the fluconazole group. The p-value was 0.08. When this paper comes out, I guarantee you we will all be arguing for days about it, right? Is this enough of a difference in invasive aspergillosis given how high risk the infection is, and a p of 0.08? The difference between a p of 0.08 and 0.05 is there's a 5% chance that it's a false finding or an 8% chance it's a false finding. So for an infection like Aspergillus, do you accept an 8% chance that this finding is not real and give caspofungin? I don't know. No differences in empiric therapy or overall survival were observed. Again, I expect this study to potentially change practice in pediatric oncology patients. And for those of you who know me, I am passionate about infection prevention and control, and I don't want to forget that. Really, in pediatric oncology patients, I think we really need to implement bundled care for our central lines, bundles of care around the placement, the frequency of dressing and tubing changes, guidance on patient bathing, duration of how long you scrub the central catheter hub, how often you go into the central catheter to draw blood or to give medications. And all of these should be organized. That's what a bundle is. It's an organized approach to how we manage catheters. It's very simple things, but have been very effective. If we look in NICU populations and PICU populations with catheter-related bloodstream infections rates, these are CDC data. Look what they've done over time with the implementation of bundles. Catheter-related bloodstream infections have significantly decreased with the use of organized bundles of care, checklists, guidelines that we all follow. And if you look at the literature, as the compliance with the bundle elements goes up, the infection rate goes down. In 2013, this was a PBC paper, pre and post intervention of central line associated bloodstream infection rates in children with cancer. After instituting a bundled care, the CLABSI rate went from 3 to 1.5, about a 50% reduction. Significant decline was realized in BMT and non-BMT populations. In 2013, Aaron Millstone in Lancet published a multi-center cluster randomized trial of chlorhexidine bathing, washing children in intensive care units with chlorhexidine daily. Chlorhexidine bathing reduced bacteremia from 5% to about 3.5%, from 5 to 3.5 per thousand days. So I hope at the end of this, I've tried to convey that antibiotic prophylaxis is effective in reducing bacteremia with minimal impact on resistance, at least with this agent. Antifungal prophylaxis with mold active agent like an echinocandin is likely better than fluconazole. I think it's time to revisit discontinuation of antibiotics in certain children with fever and neutropenia, and I think we should not forget that infection control, a key component of preventing infections in children with cancer. Thank you very much.